Yes, good evening, everyone. We welcome you all to Ortho TV Online in association with Orthopedic Research Education Foundation. To introduce today's topic and speaker, I hand over to Oref Chairman, Dr. John Mukhopadhyay.
Thank you, Neeraj. Welcome, everybody, to this webinar aimed at DNB students and postgraduate students. And today we have Professor Pal from Kolkata, who's going to give us a slightly different talk from the usual, and this is about the art of writing your theory answers. Okay, so this is something slightly out of the way, but probably really important because how you answer a question can make the difference between you passing and failing an examination, and it's important to get the examiner's perspective as to what they expect from the DNB students or the PG students when they sit for the exam. So Professor Pal, over to you, and I'm sure you're going to give us a very sort of important talk on how to answer theory papers. So over to you, Dr. Pal.
Good evening. Thank you. I'm just congratulating Dr. Mukhopadhyay for his tireless endeavor to help the students. So basically, I think this is the first time I'm going to give a lecture on this sort of topic. That is the art of writing answers to the theory questions. Because the theory is like a nightmare for all the students, right? And the students are actually feeling helpless in front of that, because there is just vast of ocean like. This is just like an ocean. So how to write the art, this is how to write the answers. It is extremely important. Now I'm going to discuss with that. So there are some general guidelines, as you can see. So first of all, we have to be very calm and quiet, and to read whole the papers and fix your targets. That is, we have to start with your easy questions to difficult. You have to think, understand, and recapitulate the assemble of the knowledge. We have to write up sequentially. In DNB, basically there are all the question marks are fixed, and there are some specific answer sheet. So there is no ambiguity, and we have to attempt all the questions. Never leave any question. This is extremely important. And ultimately, at the end of your examination, you have to revise whether any points to be added or to omit, because there are some doubt to be omit. Yes, omission is also important regarding the addition. And lastly, there are some important points to be noted for earning the higher marks, like the time allotment is extremely important. So first of all, we have to select among the 10 questions. Suppose there are 6 questions are very easy. So we have to make at least 50 to 60% time should be allotted for this 66 questions. Because for the harder questions, you have to think more, isn't it? So that is the time allotment. In this way, we have to go. Next is the spacing of writing. I'll show how the spacing is important. Next is the use of the different colors. Yes. Now, apart from the red color, you cannot use the red colors, but you can use the orange colors. Any other colors you can use that. Orange or any brown, maroon color, you can use that. Like the sketch pen or the dot pen, you can use that for highlighting. Next one is the underline and the highlighters. Yes, highlighters you can use, but you should not be much more, so that will be so irritating. Lastly, it is the ornaments. There must be some ornaments of your writing, like the flowchart, bar diagram, and this specifically the diagram or the pictures. You have to, I think this is my request to all the students to use, to practice some of the diagram. I will show how some easy diagram can be picturized and in your answer script. Now see, these are the questions I have taken from your last last examinations of the DNB. So this is the trash shell which has come. So how will you start the trash shell? Any questions, like any answers of any question should have this following, like this: segmentation, spacing, relevance. Next is diagram, scientific content, completeness, and the to the point. So see, I will start with this strash elbow introduction. See, I've written there are high energy injuries around the pediatric elbow who are apparently missed, resulting in the inadequate treatment, leading to the chronic long-term sequence with severe functional deficit. And the Kishor et al., it is in 2007, is described this injury and coined the term. Next, see the next point is the type or the enumeration of the injuries. See, these are, I have given in a flow chart in manner. These are the high energy trauma to the pediatric patients, usually below the 10 years age. Why it is common in this age group, I'll show you. So this is also a point of interest. If anybody want, you can highlight it. See, why it is a pediatric elbow is much more important because of the several sequential development of the secondary ossification center. All of you know this is a creto or cretol. So this, you can draw this. It is a very easy diagram. See, there's on the left side, it is little bit complicated diagram. On the right side is little bit easier diagram. So anybody can practice on this easier diagram, this one, and you can write in this manner, CRI like this. And we have to write in what do you mean by the CR means, what is that? And we have to write it down in this manner. It is a diagram showing the time span of appearance of the secondary ossification center and the elbow. Now, this is the flow chart of development of this strash injury. That is a high energy trauma leads to osteochondral injuries around the elbow. That means there are several enumeration. These are the epiphyseal separation, displaced intraarticular fractures, everything. I'm not going into detail. Just I am going to show you the art of writing. So I'm not going to give you knowledge because otherwise I cannot finish my lecture in time. So this is the art. Next one is the trash injury. I'm going. So in the next page, I'll write why they are missed, because they are more muscularly, they are cartilaginous, which is not visible in the radiograph. That is why in the normal radiograph, it is usually missed. So what is the importance? Because as it is an intra-articular injury, that will significantly causes the articular incongruity, and there's a degeneration of the articular cartilage. So it is much more important. Next, how they are diagnosed. How they are diagnosed, the clinical diagnostic tools. So first of all, you have to diagnose the, first to write it down, the clinical diagnostic tool. So once we write, so this is my request, this is my advice to all. Once you start to write the clinical features, always try in this manner: inspection, palpation, movement, measurement, joint proximity, as we follow the same rhythm in our practical. So clinical inspection, see, I'm writing. So if you follow this, you can easily do not miss any point, like diffuse swelling anterior and posterior, filling up the anconeus triangle and the cubital fossa. Palpation is a specific tenderness of the, see, this, you know everything, but if you write it down, if you know how to write, you can easily write. So inspection, palpation, movements, as it is a significant trauma, that's to see the elbow, that is the flexion extension motions and the forearm motions, all are restricted terminally. So how they can be diagnosed apart from the clinicals? This is high index of suspicion by clinical, and apart from the ultrasonography, arthrogram, but does not require these are important because doesn't require the sedation. But whereas the MRI scan, it is very easy, but is not required. It is not accessible to all the persons because of the monetary problem or the facility. But not only that, MRI scan require the conscious sedation. So it is extremely important. So otherwise, it is very difficult for the pediatric patient. So next one, see, why the osteochondral fractures is common in the young. See, you can write this. This is not mandatory in this answer, but you can write it. Why? Because see, there's this junction of the articular cartilage and the bone. So in the younger, the child or immature patient, these are the tight junctions. There is tight interdigitations between the articular surface and the trabecular bones. So is any shearing force occurring on this? So that will lead to that trabecular bone fails. Whereas in the adult, the inner part of the articular cartilage is calcified. It is known as the cement line. So in both the child and the adult, this junction is significantly stronger. Whereas in the adolescents, where there is a transition between these non-calcified to calcified area, so this junction is unstable and weak. That is why the osteochondral junction fails, and the osteochondral fracture is common around the age of 10 years to adolescent. So this is that. So you can write this. So that will carries importance on your that increases the reach, that is the wealth of your writing. Now management, again, once you start the management, see these 3 points you have to highlight. There's confirmation of the diagnosis by investigation. Next is the counseling and the treatment. So if there is any point of counseling is what you want to highlight, you can write it. Like the counseling of the parents are extremely important, as future functional deficit may pose the complications and medical legal issues. These are the importance of the trash injuries. So these are, you can write it. Now the treatment is simple. The proper planning is required, and as it is an intra-articular fractures, that has to be anatomically reduced, and stable internal fixation should be required. If it is completely displaced, otherwise if it is not displaced, we can do the conservative treatment. Again, the treatment, see, this is the algorithm. You can draw this sort of diagram. So you have to see the fragments, whether it is undisplaced or displaced, whether it is a small fragment or large fragment, is the incomplete fracture or complete fracture. It should be attached to any one end. That means it is relatively stable, or is completely separated from the parent bone. So see if it is all the conditions, we can go for the conservative management. Otherwise, we go for the operative management. And the operative management is basically, as I already told, is as it is an intra-articular fracture, that will require accurate anatomical reduction and stable internal fixation with the help of, there are several options, like the screws, screw anchors. Screw may be metals or bioabsorbable. There were pin tracks, the K-wires, and there may be plates and screws. And the method of surgery and the rehabilitation you can add. See, and the complications of stress injury, that is a delayed diagnosis, treatment, AVN, everything. So these are the points we can highlight in your trash injury. Now, this is a turret exostosis. So basically, what is it? It's a reactive bone formation, against the trivial trauma. Reactive bone formation against the trivial trauma opposite to the middle phalanx and the proximal phalanx of the hand. Very rarely it is seen in the talus. So in that case, you have to write it down. Again, the introduction. Next is the pathogenesis. In the pathogenesis can be drawn in this sequential manner. It is very easy, and it is very lucrative for the examiner also. And we can draw this simple diagram. There is a subperiosteal hemorrhage, then there's a periosteoitis, there's the cartilaginous metaplasia, and there is a mature bone formation. It is looking like a exostosis. Clinical feature is extremely painful, and the catch is, see, the adult parents, the catch is, you should not touch within 6 to 9 months. It is the most important. But there are several radiographic investigation, management. Again, there are confirmation of diagnosis, counseling, treatment, planning. It is important. Planning is important because if we touch these lesions within 6 months, there is high chance of recurrence. We should not touch within 6 months. And treatment offered is the excision if it is painful. So and there is the complications, recurrence if it is treated within 6 months. This is human bite. You can see again, we start with the introduction. See, there are several points in the introduction in the human. See, there's the incidence, sex, social features. As you can see, commonest site of the bite is the dorsal aspect of the third and fourth metacarpal. This is the mode of injury. Basically, they basically result from the direct clenched fist trauma. Basically, it is a fist bite. It's a fight bite. It's a fight bite, result of fight bite. We have to write the microbiology. Microbiology is extremely important. If you know, you can write it down. So that is usually is a polymicrobial. You can, if you remember, you can write this alpha hemolytic streptococcus, staphylococcus aureus, echinonella corrodens, and the gram-negative organisms. Now the clinical feature again. See, we have started the history, inspection, palpation, movement, and see every points to be covered. If you follow this technique, you can easily cover all the things. The history, that is a fight bite, that's a specific site of injury you have to mention. Then inspection, there is a wound pattern is often transverse or irregular. There is a palpation, there is a worm, there is a high rise of temperature around the wound. There will be edema, so overlying wound, like everything. Movement may be painful. So depending on the lesion, it may confine to the soft tissue or skin, subcutaneous tissue. It can involve the subcutaneous tissue, skin, as also the tendons. And ultimately, if it is a severe one, it can involve the skin, subcutaneous tissue, tendon, as well as the bones and the joints. So if the bones and joints are involved, the movements are also become painful. So everything should be examined. Now treatment, see, there's immediate management, definitive management. See, everything you will know, but you have to, if you write it in this manner, in a sequential manner, it is very easy to see, to check by the examiners, and you will got the higher marks. They wash with adequate saline or the Sablon Dettol solution, elevate the hand, everything you know, but you can write it down in a sequential manner. And the definitive management, yes, is you have to go by this specific involvement of the, whether it is confined to the soft tissue, tendons, or the bones and the joints. Now, the duration of the antibiotics depends on the number of structures involved, soft tissue, tendons, or the bones and joints. If the bones and joints are involved, there's a number of days of antibiotic will be highest, that is 4 to 6 weeks of antibiotic. Now, which sort of antibiotic? This is a broad spectrum antibiotic. We have to cover the gram-positive, gram-negative, as well as the anaerobes. So, in that case, we can add the amoxicillin, clavulanic acid, that is gentamicin, or the amic acid, or the metrozine. Otherwise, we can start with the clindamycin, because there's a broad spectrum of antibiotic and microbial spectrum. Now, there are several risk factors who will develop the infections. So these are the risk factors you can add, and the complications, that is a systemic feature, systemic spread of the infection. So see that these are the points to be completed in our human body. Now, the anterolateral decompression. The question is, what are the indication and contraindication, the principles of anterolateral decompression? So we have to write, we have to see the percentage of division of the marks. So the indications are these are the indications which is it is written along the Professor Tully's book. So it is a classical indication, you have to write it, and this is straightforward questions. But these are the points to be highlighted. Why? What is the introduction? This is surgical decompression of the spinal cord in case of tubercular spondylosis of the spine. Now the point is, why it is anterolateral? Why it's called anterolateral? Now the point is, see, the parts of the bones which is anterolateral to the cord is taken out, so that the cord is completely becomes decompressed. But there is approach, maybe there are different approaches. So why the anterolateral decompression is done is ideal, because posterior elements to be preserved. Otherwise, if the posterior elements is damaged, that will the whole lesion becomes unstable. The spine becomes unstable. So it is very difficult to manage. So posterior elements to be preserved. Any surgical stabilization, if needed, required to be placed in the posterior element. And again, the spinal fusion also require the maintenance of the integrity of the posterior element. That is why the anterolateral part of the bone, which is situated anterior to the anterolateral part to the cord, that has to be done. And this is the simple diagram. Anybody can write it down. So, and you have this has to be marked, and we have to write it down. What do you mean by the P? That is the pedicle, VV for the vertebral body, TB for the transverse process, R for the ribs. So this is the costotransversectomy, as well as the anterolateral decompression composite for decompression. Now, what are the surgical approaches? So for anterolateral decompression, so it may be transpleural anterior, extrapleural anterolateral, retroperitoneal. So these are the points. Now, why it is anterolateral? So as the anterolateral decompression is the point, so we have to highlight the advantage of the anterolateral decompression. See, for the direct decompression from D1 to L1, anterior approach is the best. Anterior transpleural is the best. But due to some compromised pulmonary function or the comorbidities, this approach leads to high complications. That is why the anterolateral approach, which is an adequate approach, which can for decompression from D2 to a lumbosacral spine. See, extrapleural anterolateral, it is effective for D2 to L1, whereas the rest of the lumbosacral region, retroperitoneal anterolateral decompression is the so all the cases anterolateral decompression is the most important. It is effective method, and so it can be used. So this is the advantage of this. Now, if you want to highlight, if you ask to highlight the technique, then these are the points to be followed. Now, position, incision, muscle pain, guide to spinal cord. Next is what is the guide to the spinal cord? Everybody knows that is the segmental, that is the intercostal nerves. So these are the points we have to be highlight. Principles of decompression, spinal stabilization in the form of the cage or the bone grafts like that, and the postoperative care. Now, another important question has come is the triage. How will you write it down? See, these are the points to be followed. The introduction, importance of triage, preparation, how to prepare for the triage team. But there is a team, always there is a trauma team. How the trauma team will prepare for the triage, that is also important. We have to highlight in this answer. And another important point is actual method of the triage, how it can be done with example. So this is the introduction. So triage is the sorting of the patients based on the need for the treatment and the available resources to provide that treatment. Ideally, it must be followed right from the site of the accident. This is the place. What is the place of the triage? This is the site of the accident. So triage, see, this is the introduction, the same. There's a preparation. So how the triage team will prepare for the triage. So first is the scene size up. So we have to see whether the scene is safe for the team for making the triage. It is extremely important. So if there is scene in this a bomb blast situation, there must be some other areas where there is the possibility of blasting of other bombs. So it is very difficult to go everybody for any part of the rescue team to go there for the triage. So we have to follow this. First, the scene size up. Next is the check the scene, call for the help. We have to see how much the victims. If the number of victims is extremely more, so we call for the help for first. Otherwise, triage will not be effective. Next is the actual method of the triage. Lastly, the urgent life-saving measures for the persons who require the emergency treatment. Lastly, the transport. Why it is important? What is the importance of the triage? Because there are three modalities of the death. So some persons immediately dies because of several great injuries, great vessel injury, severe head injury like that. Or some persons usually die within 2 to 4 hours, and there are third peak of death which is within weeks. So these are the second and third peak which can be preventable with the help of the effective triage. How it can be effective? Because our priority, we have to set our priority like the life salvage first, then the limb salvage first, then second, and lastly the salvage of the total functions if it is possible. So and that can only be done with the help of the triage. These are the scene safety. I'm not going to detail. These are the total number of victims. We have to see we have to have some specific equipments before going to triage like that. So I'm not going to detail. Basically, this is what is the actual method of triage. So this is basically, it is all the victims, they are classified with the help of the color code. The red one is the immediate and critical. It's the yellow one is the urgent, can wait 30 minutes. Category 3 is the delayed, less serious injury, and the 4 is day. That is we cannot do anything. So P1, this is life-threatening. P1, P2, 4. P4 is the dead. So there's what are the examples? C is the life-threatening injury, is a tension pneumothorax. P2 is the urgent, that means the fractured femur. P3 is the minor, that is sprained ankle, and the 4 is the dead. So how you classify? How you do that? So this is the four important points. The points that we have to see whether the patient is able to walk or not. If it is yes, this is a P3, is a minor injury. The next, we have to see whether there is a breathing. No breathing. So we have to see whether the airway is opened or not. There's no airway breathing is not, airway is not opening. It cannot be opened. So it is an extremely serious injury. Okay. But if it is a yes, it is open. Respiratory, you have to see the respiratory rate. If the respiratory is abnormal, that is less than 10 or more than 30, again, it is very serious. It is very critical. It is extremely critical. Next, we have to see the respiratory rate is 10 to 30. That is within the normal. Then we have to see the capillary return. If the capillary return is more than 2 seconds, that is, it is delayed. Delayed return. So that is extreme. Again, it is critical. Again, but if it is the capillary return is less than 2 seconds, that means it is normal. That is, it is relatively less. It is a minor injury. So in this way, we have to triage. We have to classify this. So this is the method. Next is the signs amputation. Second, you have to see. We have to start with the introduction. There's indications. If we start with the indications, it is very easy to like this dead, dangerous, and the damn nuisance. So dead, there are a few some infections like gangrene, ischemia from peripheral vascular disease, or see the dangerous is severe infection, or the damn nuisance is the non-functional congenital abnormality with or without sensory deficit. Is the damn nuisance. So these are the indication of the any amputation. You can write it down. So in this rhythm. So if you come any type of amputation, if you come, you can write it down in this manner. Just the indications may be changed, but these points may be same. Now the procedures, they may be classical procedures. You have to write it down in this manner. So these are the procedures. The bone transection and distal tibia and fibula. These are classical procedures. But see, there are some modifications. The modification is the Pirogov's modification. See, there is some part of the this calcaneum is kept, and this part of the calcaneum is faced against the distal surface of the articular surface. So this is the Pirogov's modification. Another modification is done by the Sarmiento. So these are the modifications. You have to add this. Modification is Sarmiento. Sarmiento, which we suggested to cut the tibia fibula a little bit higher enough, because in the lower part, as the tibia fibula is little bit flared enough, so there is a bulbous stump, which is very cosmetically it is unacceptable, and that can the fitting of the prosthesis is a little bit difficult. So if you cut the bone a little bit higher enough, so it make a very rounded stump, and this is very easy cosmetically. It is acceptable, and there's a fitting of the prosthesis is also easy. So, and that is the modification of the Sarmiento. So there are two modifications. One is the Pyrogov's modification, another is the Sarmiento's modification. Again, that can be done in different stages: one stage operation, two stage operation, or modified amputation. So these are you can add this. Now, brief procedures. I'm not going to tell you have to brief procedures of amputation you can add. Next, the rehabilitation. This is also, you have to, once any type of amputation, you have to add some rehabilitation. So you have to rehabilitation in this manner. This is universal. Like stump care, you have to position of the stump, stump exercise, cleaning, bandaging and shaping, everything we have to add. And even for this, there's an end-bearing stump. Even without prosthesis, patient can bear the weight. So this is, there are Symes prosthesis. There are several different types of Symes prosthesis. I'm not going into detail. There is a Canadian socket, bivalve socket, stiff dysfunction, and there are some problems. First of all, next one, we have to highlight some problems of the amputation. These are the height adjustment problem is there. This end bulbous stump, which is corrected by the Sarmiento's modification, Dunning-Duffing problem, lack of cosmesis. Next, the reverse shoulder. It is a straight way. It is a direct. There are some questions will be a little bit straight way questions, and so you have to check your temptation to write more. So we have to draw this sort of diagram. Because it is a little bit different from the conventional prosthesis. But we have to write it down. This is the same introduction, indication, contraindication of this reverse shoulder. Next is the planning. It is extremely important because you can write it if you even without reading. If you suppose the indications basically is the rotator cuff deficiency. Rotator cuff deficient shoulders is the basic indication. So you have to write it down. Well, so whatever, there are several other points you can just forget, but that point should be there. But this is the most important point that must be. See, these are not very critical. So candidate should be non-smoker. Bone should be strong, not osteoporotic. Joint should be healthy shoulder socket. Muscle should be normal function of the deltoid. Nerve intact, brachial plexus nerve functions. And the surgeon should be technically expert. So these are the components. If you remember this, you can write it down. Next is the advantage and disadvantages, and lastly the complications. So these are the points to be highlighted for this reversed shoulder. Next is the total contact cast. What is that? It's the introduction. It's the total contact cast is specially designed cast to offload the knee, offload the foot. Why? If the sole of the foot is insensitive, so there is a concentration of the pressure on the sole that can lead to some pressure ulcer, which may lead to the amputation. So to prevent that, we can use this total contact cast. So you have to write it down in this manner: introduction, definition in neuropathic foot, and see. So these are the points. How it works. See, there are several points like diabetes mellitus, infections, like the nerve injury, also the peripheral neuropathy, all will to insensitive skin. And along with that, if there is addition of the mechanical factors like the excessive the body weight, excessive pressure of the body weight, shear forces from the footwear, the repetitive stress during the walking, all will lead to concentration of the load in the natural pressure area. That is why I have drawn this diagram. This is the normal footprint, as where the first the pressure is coming on the heel, and then the pressure is going on the lateral border of the foot to the head of the metatarsal. This is the way of how the foot carries the pressure. Now, if there is insensitive skin and there is abnormal mechanical factors, that is an absolute increased concentration of the pressure on these pressure areas, normal pressure areas, and that will lead to pressure ulcer. So how the total contact cast helps? That causes the offloading of the bone, offloading of this foot, and that will help the pressure ulcer to heal. So how it works? That causes the offloading of the foot, which causes healing. Now, what are the classification of the offloading devices? You can write it down. That will increase your volume and the wealth of your writing. So there are two types of offloading devices: the removable device. There are several removable, like the Prof boot, there's ortho wedge, removable boot, or the roll-on TCC orthosis. These are the patient can easily remove that. But there's the irreversible devices, which is under control of the clinician, the orthopedic surgeon. That is basically the total contact cast, which is made up of the plaster of Paris or the fiberglass. And according to the Cochrane review, this is the most effective offloading devices for these pressure ulcers or the neuropathic neuropathic foot. And how it works? It reduces the stride length, it immobilizes the ankle, and it redistributes the forces. That is how it reduces the stress concentration. So these are the points we have to highlight now. Now the advantage, disadvantage of this total contact cast, we have to highlight. So that these are the points for the total contact cast. Now another question comes, this is a diagram of the cross section of the spinal cord. So we have to write it down. First of all, you have to write it down. See, this is very easy diagram, and these are the points to be highlighted. These are the these are the tracks, the spinothalamic tract. This is a lateral spinothalamic tract. This is the anterior spinothalamic tract. And the blue one is the corticospinal tracts. Basically, this is a descending pathway. And see, the green one is the dorsal column. So, and this is the, that is looking like a butterfly. This is the actually the gray area which containing the cell bodies, and the white areas they basically it is containing the axons and the fibers. So this is the cross section. And what is the importance? There are several different syndromes, whether the anterior cord syndrome, central cord syndrome, Brown-Sequard syndrome. They can easily advise. We can by this diagram we have to practice it. Another is the Coleman block test. Coleman block test. So if it is, what is that? So first you have to write it down, the introduction. Basically, it is the test to detect whether the hind foot varus is primary or secondary. So how do I detect the hind foot varus? Always examine the patient from the inspection from the back. When the patient standing in anatomical position, examiner will stand on the behind the patient to see whether his heel is shifted towards the midline. So that is the way how to diagnose the heel varus. Now, whether this heel varus is primary or secondary, that is detected by this Coleman block test. So for this, you have to understand, suppose this is the first metatarsal. See, this is the first metatarsal, and there are two tendons controls the first metatarsal. On the medial side, so this is the tibialis anterior, and on the plantar surface on the lateral side, there is a peroneus longus. So if the tibialis anterior is paralyzed, but the peroneus longus is normal, so what will happen? So if it contracts much more, that will cause that is dropping of the first metatarsal. So there's a background is tibial. There's a tibialis anterior paralysis with normal peroneus longus, that will first metatarsal drops and the forefoot pronate. So so that to compensate this deformity, heel becomes varus secondarily to enable the pronated forefoot to the ground. So that is the most important. So that is the secondary heel varus. Now how it helps? In actually this test is done, ask the patient to stand on the block, keeping the whole of the foot first, and then next we have to ask the patient to stand on the whole stand on the block, keeping this medial ray just out of the block, and we have to see whether there is a changing of the heel. So this is the one. See, this is the condition. When the patient stands, the heel is varus. When the patient stands with the medial ray is outside that block, heel becomes normal. So that is how indicates it is heel is secondary or heel is supple. But see, this is the case. Once the medial ray is outside the block, still the heel becomes varus. That indicates that heel varus is secondary or it is very rigid enough. So that in that case, how it be important? Because if the heel varus is secondary, then no treatment is required for the heel varus. Treat by the primary cause. So it is easily corrected. But if the heel varus is primary one, or it is rigid one, that has to be corrected. So that is extremely important for diagnosed by the Coleman block test. Now, DVD prophylaxis, again, it is a straightforward question. We have to go by the introduction, and there are several conditions, and then what are the patients, ideal candidate who require the DVTs. So that's the long list can go directly. So several, you have to control yourself to not more than just. We have the important point. We have to write it down. So in this manner, so commonly used pharmacological agents for prophylaxis is low molecular weight heparin, non-fractionated heparin, fondaparinase, like that. Duration, you have to write it down, and the role of aspirin and the post-thrombotic syndrome, it you have to write. There's another important is that this arterial osteoplastic amputation, it has come. So it is what it is. Normally, what is seen once we cut the bone, either transtibial or transfemoral, normally we keep the medullary canal open, but that may lead to some complications. So arterial is hypothesized that if we block the medullary canal, that increases the homeostasis inside the bone, that increases the functional outcome. So that is this arterial osteoplastic amputation, and this is the introduction. And see, there are several These are the theory or this osteoplasty theory that he advocated. This medullary cavity should be blocked. So see, there are two ways they can block the medullary cavity. So that is how they do that. You can write it down in the diagram. See, especially he used for these transtibial amputations. So what he did, so he took the part of the fibula, and he make a communication between the tibia and the fibula along with the osteopediosteal flap to cover it, so that that will act as an effective end-bearing amputation. So that is the way. So there are two ways. One is the osteopediosteal flap, only simple osteopediosteal flap. Another is the fibular bone block, which I have shown it. So these are the two ways by they can block the medullary canal. And they claim that if they block in this manner, that will act functionally better. And the fitting of the prosthesis is also very good. So there are several advantages of the end-bearing prosthesis, and you can write it down in this manner. So this is arterial osteoplasty. Now, septic versus hypothalamic shock. So these are the way you can write it down in this manner. Arterial hypotension, tachycardia, cardiac output. So you have to write it down whether it is present or absent or like that. Next is they have asked for the management of the septic shock. So for management of septic shock, we can write it down in the simple ways. That is the simple basic pathway of any shock, because we have to block the basic pathway. And specifically for the septic shock, this is an a la carte approach. If the patient has come within 6 hours, there is a surviving sepsis campaign within 6 hour bundle. So what are the points? What are the works to be done within 6 hours bundle? If the patient has come with the 6 hours bundle. If the patient has come in 3 hours, there are 3 hours bundle. But now the recent technique is the 1 hour bundle. So what are the points to be done? We have to do the blood culture, broad spectrum antibiotics, start antibiotic fluid resuscitation, everything we have to done one by one. And see, these are the points. Why? What are the intravenous antibiotic? What are the points to be added? Everything we have to add like this. Now, this is the references who advocated for this 1 hour bundle management. If that is, this 1 hour bundle should be viewed as a quality improvement opportunity for management of the septic shock. This is the references we can add. Next is the femoral anteversion with the ages. Femoral anteversion. Femoral anteversion with the ages is basically femoral anteversion is 30 degree at birth, and it will gradually decrease from 30 to 40 degree to 10 to 15 degree by the early adolescence. Most of the improvement occurs before the age of 8 years. After 8 years is becomes almost fixed. So this is the point. And another question comes is development of the neck shaft angle with the ages of the time. There's 1 year, 3 year, 5 year, 9 year, and 15 year, like that. See, it is at 1 year. It is a 1 AB is at the 1 year. This is almost it is at 130, it is 150 to 148 degree. Whereas in the 15 years, it is 15 years. Since it's 15 years, it is 130 degree to 120 degree. So this is the hereditary difference as per the Hefty 2007. So you can write it down in this manner. Otherwise, you can mention it. Next is the hind foot arthrodesis intramedullary nail. It is a tibio-talocalcaneal arthrodesis nail. This is a planning and preparation. In this manner you can do that. Since you have to do some imaging is required. The liquid bearing anteroposterior lateral mortise view, evaluate the joints based narrowing. Post-traumatic arthritis is the most common etiology. Many have the varus valgus deformity that should be corrected during this insertion of the nail. Now the preparation, we have to point down the preparation. There's the positioning of the patient. Next, the approach. I'm not going to detail. The operative step is one by one. You can write it down. There's a post-operative and the complications. So as it is a straightforward, I'm not going to detail. The Bostrom procedures, it is for the lateral ankle ligament sprain or chronic lateral ligament injury, where there is an end-to-end repair is done. The procedure goals is to improve the stability on the lateral side, where there is a chronic lateral ligament tear. So especially for the athletes, so it is anatomical reconstruction is done with the help of the end-to-end repair. And as the end-to-end repair is attempted, there is no restriction of the subtalar joint motion. So that is ideal for the athletes, dancers, everyone. And these are the procedures. These are procedures one by one. That is the position, incision, everything. We have to go one by one. You can write it. I can just make a diagram like this. this small incision. This is tibia and fibula, and so you can make a small incision just over the across the tibia and fibula. You can write. You can. This is very easy diagram. You can practice it. This is the external. This extensor retinaculum. This is a torn or lax. This is the anterior talofibular ligament. This is a calcaneofibular ligament, and that can be easily repaired. End-to-end repair, like the same like the vest inside the pant. Same thing. Vest inside the pant. Repair. Basically, it is a repair of the end-to-end repair of the anterior talofibular ligament, calcaneotalofibular ligament, and even after the repair, that can be reinforced with the help of this. That is the extensor retinaculum. It is brought towards the fibula, and through the suture, we can suture this this extensor retinaculum. The same in this manner is Evans actually they modified this with the help that it splits the peroneus brevis tendon. He cut the peroneus brevis tendon over here, and he passed this peroneus brevis tendon through the fibula, and it is attached over this. So this is the Evans modification. We can add this along the Brom's. So there are some risk procedures like general risk. Any complications of the procedure, there is some general complication. We have to write in an infection, wound healing. There's a general complication. You can write it down. This is easy. And there are some specific complication. If you know, you have to write it down. Like the specific complications of the Bromstrong is this injury of the superficial peroneal nerve and the stretching out of the repair is extremely important. That is why the Evans added with this peroneus brevis split transfer. Moral level lesion. Yes, it is the introduction. The moral level lesion is a closed internal degloving where there is a dermis. The dermis is separated from the superficial fascia. Deep fascia, sorry. Dermis is there is a collection of the hematoma between the dermis and the deep fascia. You can easily draw this diagram. And the pathology is injuries typically caused by the vertical shearing force, and there especially is associated with some major road traffic accidents associated with them pelvic injuries. Investigations, basically MRI is the investigation of the choice. There are several treatments like the compression bandaging, percutaneous aspiration, but sometimes it may recur. So this ideal treatment is open debridement with the degloved radius. But point is there is some permanent damage of the blood vessels which are coming from the dermis to the skin. So beware of that, and in that sense you have to counsel. Tendinosis. Yes. So can I stop here? Can I stop or any take questions, Janki? Because there are several questions. I cannot finish.
I know. I mean, you don't. I think it was great. I think people should have learned a lot from that, and I think they will probably have some questions which would probably be wise to.
I want to summarize. So once we have got the questions, first of all, we have to see. So we have to read all the questions. First, always attempt from the harder, from easier to harder one. So always try to make this segmentation, the introduction, there's classification, and give some ornamentation like the leveling, the flow chart or the diagram. I have already shown how the diagram should be done, and always revise it, omit or the some addition. Okay, I'm love to ask for questions. Any questions?
So, sir, can you please stop the slides here?
Yes.
So I think we should start with the DNVs. So please ask your doubts. And one thing, sir, which I want to ask, is there any like subdivision of the papers, the topics in the papers in first paper or second paper? What is they used to ask in DNB?
Pardon, what is the question?
Subdivision of topics in paper 1 and paper 2, like for the MS and all, it is type. The paper 4 is for recent advances. So in the
pattern of questions are relatively same now. Everywhere there are 10 questions. Everywhere there is 10 questions, and they have to write it down. In a DNB, what is done? There are answer scripts are specifically marked for question numbers. So you have to attend. Suppose there are 5 papers allotted for each questions. 5 papers. So there is a question number 1 first, then after 5 paper, there is from 6th paper it is marked as question number 2. So you have to write it down the exact answer to exact question. Now there are segmentation of the marks. Suppose it is given what is the basic difference between the septic shock from hypovolemic shock. It is given for 2 marks, and then another marks is given. Give some brief outline of your management of the septic shock. So, and that is the 8 marks. So 2 plus 8. So always we have understand if you give some less weightage to the classification difference. So give some 4 or 5 salient salient features in the difference between the hypovolemic and septic, and give some much more importance on the management of the septic shock. So that is most important. So in that case, we have to write it down first. We have to there's some basic outline of the shock. Now general outline of the shock management, and then the specific management. Like I've shown it in the there's a 6 minutes bundle, 3 minutes bundle, 1 minutes bundle. Now it is most important is 1 minutes bundle, and we have to write it down the explanation of each acts which is done within 1 minute bundle. And then if there is some complications, we have to do some complications like this. So this is the basic protocol of answering of any question, whether it is a question paper 1, 2, or 3 like that.
I believe for the DNP now they have no choice in the order. They have to answer them in the order that the questions are. Is that true?
But if anybody wants, suppose that the number 2 question is looking harder, and so first you have to answer the answer of question number 1, and go for the question number 7. So after 1, so they have to skip the number of pages, because some pages are specifically printed that has to be marked for specific answers. So we have to go for the 35th number of paper to write it down the answer of the 7th question. That is
one question from Dr. Anu Bhattacharya is asking if direct question regarding diagram of cross section of spinal cord, as they have asked, do we need to write about disease regarding different tracts?
Yes, you can write it down, but there is very brief. But only they have asked for the cross section. So we have to give concentration on the cross section of the spinal cord. So cross section of spinal cord means you have to see the cross section of the brainstem. You can write it down. You can cross section of the cervical cord. You can give some cross section of the thoracolumbar cord. Because cross section of the cervical and the lumbar cord will be little bit different than the thoracolumbar, because in thoracolumbar there will be lateral horn. So this carries the marks. If you give a single cross section, and then he will get less marks. But if anybody gives 3 cross section, they will get the much more marks. You understand?
Because time is quite limited, sir. So,
but after that you can add. If you want to highlight that the importance of this cross section, that will come later on. But the cross section means you have to go see they ask for the anatomy basically and the functions. Basically anatomy along with the functions, depending on the different locations of the spinal.
One question from Dr. Rajiv is asking, what is the principle of tibio-talar nail?
Yes, the principle of tibio-talar nail is basically I have already shown in my lecture. That is a tibio-talar arthrodesis nail. So if there is there is a disease which is amenable for reconstruction, like the severe crushed injury of the foot, like the severe bond injury, like severe bond, which will affecting the severe soft tissue injury, which as there is severe soft tissue, we cannot touch the skin. There are several other any other operation will become fail. So in that case, if we introduce the nail from the non-articular portion of the calcaneum through the talus to the tibia, and just fix it with the help of the 2 screws in the tibia and this and 2 large screw on the calcaneum, this is sufficient enough for providing the arthrodesis. So that is the principle. If there is significant damage of the bone osseous structure which is unreconstructible, as well as there are severe soft tissue injuries where there is a high chance of complications by open operations. So basically these are the role where there will go for this tibio-talar nail. These are basics.
So one more doubt about that one, sir, is that for the DNB, when you are checking the paper, sir, do you advise to draw a diagram in each question wherever possible, as you have shown in your chart? And is there any marks for the diagram?
See,
is there division of marks?
Basically for the impression. This is basically for the impression. So suppose you are writing everything in your paragraph, but if you give a simple diagram like anterolateral decompression, this is very easy to understand, and for the getting the good impression by the examiner. So everybody has to practice. I think this is my request or advice to all the students, to practice very easy diagram. It's not very difficult. So that will carries impression, that increases the mark. That is the ornamentation of your answer script.
So I think the idea is that it's not a rule that every question you have to draw a diagram.
Exactly.
Wherever it can improve the understanding or make things easier to understand, it's always a useful thing.
Exactly.
Okay? So if you can, it's like a flow chart. So it makes things much easier for the examiner to understand what you're trying to say, because he also has a limited amount of time to go through the question papers. So if you give a good diagram which shows the relevant anatomy, say in a certain situation, okay, we're doing some, say the classification of proximal humerus fractures. You just give one diagram showing the 4 parts of the proximal humerus, it makes it much easier for the examiner to understand what you're talking about. So I think it's relevant diagrams are important. It doesn't mean you have to draw a diagram for every question. I mean, there's some questions may not be suitable for a diagram.
Very easier for if there is time limit is very less. So you have to write it down. There are several type 1, type 2, type 3, type 4. But it's very easy to write it down. Just make a diagram, as Dr. John suggested. The proximal humeral fracture. There's a what are the parts of the fracture? Just may draw a diagram of the proximal humerus, and this is part 1, part 2, part 3, part 4. It's very easy. It's part of the fractures. That will save the time also.
So I think depending on the type of question, either a diagram or a flow chart makes a big difference.
Exactly.
Yeah, and it saves quite a lot of time also, sir, for them. So one more doubts about the.
Is there? Dr. Jain Pal is also there. So is there any opinion, Dr. Pal? He is also professor and head of MGM Medical College. Yes.
Sir, please unmute yourself, sir.
Unmute yourself.
Unmute. You need to unmute.
Unmute. Please unmute. Please unmute yourself. Dr. Paul, please unmute yourself.
Oh. Actually, regarding diagram is very interesting and very useful for answering questions. But during my experience while examining the papers, I have seen that many diagrams has been drawn which are absolutely not necessary.
Yeah,
so avoid those diagrams, and where the diagrams are very useful, then it will impress the examiner to carry a better mark. So that also to be taken care of by the students.
I think the really important thing is for people to practice answering questions.
Yes, exactly.
Something which you have to understand, because nobody who hasn't practiced questions can, in spite of however knowledge he has, he can go down and write what is important in that specific amount of time. So you have to keep practicing answering questions within a certain time, and then try to get all the important points in there. Okay, so this will only come with doing it again and again and again.
John, one more point is to answer, they first think over the question, what is exactly wanted, and that is not better understood, and something irrelevant has been written, and it becomes a shortage of time to the student also. So first understand the question, what is exactly wanted, and be specific to answer to that point. So that is very important for learning.
So I would ask Dr. Pal and both of you one thing, that there's like this time there were a few questions which some of the students probably didn't know anything about. Okay, so how do you react to that situation when you're doing a paper?
Just a minute, please repeat your question.
So there were one or two questions, I think, where some of the students did not know anything about that.
Yes, students didn't know. Students, some questions yes, some questions may come which I absolutely not. Suppose I'm telling turrets exostosis. Turrets exostosis is basically it's almost if you don't.
So the first thing is whether such questions should be there at all. And the second thing is, if they are there and you don't know anything about it, how do you approach them?
So if you ask that questions, from my opinion, we should not give some this sort of questions, which is not
absolutely, yeah, I think
not very common. And actually, we are going to check the aptitude of the students. So in theory, actually, what is our opinion? What is our aim of evaluation of a student? Aim of evaluation of student, how much they are very much expert for managing the common situations. So that
absolutely, yeah.
So if we give some questions, so it is very difficult to answer them also. So in that case, we'll what I do actually, I am very lenient and for those cases. So if anybody writes down this exostosis, it's like in any type of exostosis like this. Turrets exostosis, basically it is looking like exostosis of the phalangeal bone. But if anybody writes down the exostosis and there is how it's a benign tumor and how they examine it, how the clinical feature, the infection pattern and movement, everything. So I can usually, in my opinion, to give some marks.
Some marks for that, yeah.
Actually, I have one experience in my MS examination. One question was in management of intra-articular fractures. So it is absolutely non-specific question. And here, when I answered it, then I was totally convinced that I have done the right thing, and I was very satisfied with answering it. So the attitude in that case, intra-articular fractures. So the approach should be like that. What are the problems of intra-articular fractures? Basic common problems of the intra-articular fracture. So if we start like that, then how we can solve those intra-articular fractures? And in that way, if the approach is, so the answer will be a convincing one. So,
yeah. So that is a situation where there is so much that it's difficult to condense your answer.
Yes.
But there are questions like this time. There were a few questions which it's possible that the examinee did not know anything about it. Like one of them is that turret exostosis, the other is these bundles, etc., of septic management, etc. And it's possible that they have not even heard of this in their time. And that, I think, questions like that ideally should not be asked in a DMB exam, I think.
Turret exostosis. You were talking about
one was turret exostosis.
Yes, turret exostosis, and which is actually part of the disease process of Nora's disease, actually.
Exactly, yeah. But it's not a question, not something we come across. I mean,
yes, exactly.
A lot of us won't even come across it in our life.
It is very difficult to answer that question, which is not,
unless you know about it. If you know about it, it's great. But if you don't, then you're stuck.
My approach is, suppose we cannot do, because we don't know everything in our field, isn't it? But sometimes, suppose it's a CAFE's disease. CAFE's disease, we can see the CAFE's disease either once or twice in a year, twice in a lifetime. So in that case, suppose I have seen the case the first time. So we may not know that, but my approach should be safe. So we have to examine the answer script in the same direction, whether this approach is safe or not. So suppose
so I think the way to go about something like would be talk about what exostosis is and how you go about it.
Exactly.
Then it depends on the examiner.
Then I have to give there is pass marks. I shall give the pass marks.
But in that respect, I have one suggestion. That is, when the students are going reading, then probably in MS examination, most of the subjects she must be knowing. So when something is unknown, that becomes a lacunae for the students. So what I would advise the students, that is to only the etiopathogenesis, only know the etiopathogenesis of a disease. The rare diseases, you now learn about the etiopathogenesis and nothing else, because it is not possible to learn each and every point, every disease. It is not possible. So etiopathogenesis, if it is learned, then he can reconstruct the.
I can give the tips. I can give the tips.
Yes.
So for the trauma and the disease, for the trauma, so any type of trauma. So if you understand this is a traumatic disease, I start with this. Trauma must start with the mechanism of injury. The mechanism of injury may be a direct trauma or it may be indirect trauma. Same thing. Even without knowing anything, we can write it down. Direct trauma or indirect trauma, or it may be significant trauma, it may be trivial trauma. Now classification of any fracture. It's a traumatic, that means it is either fracture, fracture dislocation, or the dislocation. If a fracture, you can classify easily as open fracture or as a closed fracture, it's polytrauma or it's a single trauma. If it is a single trauma, that maybe it is a complicated, like the comminuted or wedge fracture, or it is a oblique like this. Now come to the clinical feature. So any traumatic condition, always any type of clinical feature start with the history. Next is the inspection, palpation, movement, measurement. Next come to the management. Management always start with the three component. One is the first is the confirmation of diagnosis by the investigation. Next the counseling. Next the actual treatment. Again, the actual treatment may be conservative, semi-conservative, and operative. Again, investigation. Like it is a invasive investigation, or it may be semi-invasive investigation, or it may be it's a non-invasive investigation, like radiograph, CT scan, MRI, non-invasive investigation. But semi-invasive means the MR arthrogram. This is semi-invasive investigation. Again, invasive investigation is the biopsy. Next, come to the complications. So, mechanism of injury, classification, clinical feature. Next, to the management, and then complications and management of the complications. So, if you see how much segmentation we have already done for any traumatic disease. So, you can write it down. Again, come to the disease. For the disease, start with the etiopathogen, as Dr. Pal suggested. Start with the etiopathology. Etiology or etiopathogenesis. And before that, always start with the introduction. Next the etiology, pathogenesis. Again, for the disease, start with the clinical feature. Next come after that management. Again, management means the investigation, counseling, and the treatment. Again, after that, the complications and management of complications. So any trauma and the disease. So these are the normal segmentation anybody can do during the writing. So it is my tips for writing any type of sort of disease or trauma.
Okay, great. I think it's already 8 o'clock. So if there are no other burning questions, I think we should call it a day.
Sir, I have one doubt, sir.
Okay, yeah.
Sir, regarding the use of colors in examination, answering the examination, there were instructions about the use of only black or blue pen, but many of my friends used different colors for drawing the diagram or drawing.
If there is instruction, always you have to follow that instruction. Don't go outside the instruction. That is the
If they've specified in the paper that you only use black and blue, then I think if you use colors, you may be penalized for it. Okay. So I think if you haven't used it, be happy. Don't worry about what others have used.
Yes.
Okay. I think great. Thank you very much, Professor Pal. That was really very instructive. And I'm sure all the students have learned a lot from it. And thank you, Professor Pal, for also joining us. And we'll call it a day today and meet again next. Okay.
Next week on Wednesday, sir.
Okay. Next week is going to be on Wednesday because I'm actually traveling on Tuesday, but and it will be Professor Anil Bhatt from Manipal who's going to be talking. I think you'll get the details of it in the near future. Okay.
Thank you so much.
Thank you, John.
Bye, everybody.
Thank you,
Thank
sir.
you so much.
Thank you all.
Thank you.
we take it.
Thank you, sir.